Well, thank you everybody for those who are here and at home. For those who don't know me, I am Lalo, one of the medical providers at the Wound Clinic, serving the community. I'm happy to talk to you about some of the evolving evidence about renal cancer. This is a very sensitive subject for many of us and our community. And there are evolving concepts, and I have lots of topics to cover. That I'm trying to do this in a very practical manner because there are different concepts. Let's see how much we can cover today. I think it's very important to start defining what is the status of the problem today from the epidemiological standpoint of view. We have done this several times in different ways, but I want to provide you a different spin today. So to play things into perspective. So let me point out that in the most recent survey of our country, the United States, which is 2021, approximately 7 out of 100,000 women in the general population are at risk of cervical cancer. 7 of 100,000. When you compare with the close to 2 per 100,000 at the same time in anal cancer, it's approximately 3.3-fold the difference, right? 3.3-fold the difference between cervical cancer and anal cancer in the general population. But let me take you back in time. And let's go back to the early 1970s. In the early 1970s, the rate of anal cancer was 0.2, poquito, 0.2. And the rates of anal cancer, the cervical cancer back then, it was 14, 74 higher difference. And those rates of cervical cancer were already down from 45 when we started screening and implementation in the 1930s. And yes, in the right part of the graphic, you see that our brothers and sisters living with HIV are at the highest risk, close to 45 to 50 times higher than the general population in terms of rate. But my point is to say the following. The difference between the 74 and now the 3.3 difference, with anal cancer increasing every year, close to 3%, and more importantly, the deaths attributed to anal cancer is simply because, unlike cervical cancer, we have neglected to implement public health policies, the consistent surveillance and screening. And for those of you who like history and also epidemiology, let me make a statement reminding you that when we implemented cervical cancer, we didn't know screening programs that even HPV existed. So just to play things into perspective. I think this is reflecting another important point, why the rates are increasing. It's not moving, Marvin, but no.
Okay.
Oh, yeah. Okay. It's reflecting one key important point. Yes, our brothers and sisters living with HIV are an increased risk of anal cancer, but they are not the only population at risk. I heard from our fellows a very interesting term, which is organic medicine, which is the comes with social disparity for health. But then what we induce to our patients with an immunosuppression, and now in modern medicine, there are risks of different populations, such as solid organ transplantations and other immunosuppressions, that are at risk of persistent HPV infection. And as you can see, all people with HIV, men who have sex with men, men who have sex with women, women who have sex with men, are at disproportionately higher risk, more than the 25 per 100,000 threshold. But also increasingly, you see there is all of these immunosuppressed HIV population that we are learning that are also an increased risk of HPV persistence and increase of rates of anal cancer. Another point to make is that the highest risk in women for for anal cancer when they don't have HIV is not to have cervical dysplasia, it's actually to have vulvar dysplasia or prior history of vulvar cancer. Having said that, there are key points from this epidemiological review and potpourri that I want to highlight. Number one is that yes, the anal cancer rates continue to increase, especially among people with immunosuppression. Of course, the risk is highest among people with HIV. The current incidence rate of cervical cancer in the general population has decreased to 3.3-fold difference relatively to the anal cancer comparing to the 70-fold. And I think this reflects a concerning neglect in public health interventions for anal cancer prevention, and something needs to be done about this. Okay? So the next important point before we go to really
Use the mouse. Just click on it. No.
the next important point, I think, is we really need to discuss what are important concepts of how to
Just click. Oh, no.
okay. How to really, there are some important translational contexts that are relevant to the conversations and clinical applications when we are at the bedside. And I think the intent of these slides is not to discuss molecular epidemiology or molecular translational research, but practical points that correlate with the clinical decision-making and a lot of misinformation and misperceptions about the subject. There are three general steps, generally speaking, about the HPV infectivity cycles. Number one, during intimacy, there has to be some sort of mucosal abrasion that facilitates the entrance to the baseline. It's like on the further left of the virus to the basal membrane. And again, intimacy is a personal individual ritual of partners. There is no need for anal sexual intercourse to facilitate introduction of HPV in the anal canal, just to make that clear point. Second, is that once it gets to the baseline membrane, the virus stays there for a long time. It sits for one full day almost, because it needs to undergo configurational changes so it can be uptaken into the baseline epithelium. From there, go to the cycle, we try to survive and go through different stages of replication. The practical point why is so important that it stays 24 hours waiting to be uptaken and transforming before, because I think that's one of the key reasons why the vaccine is so effective. Because primary prevention, when you have the lipoprotein-based particle for prevention, the HPV vaccine, nowadays we use the nanovalent, blocks at this level. This is the reason why it's so effective in primary prevention. Okay, so there are plenty of opportunities to act while the virus is waiting and sitting to be uptaken. And the third one, as I told you, the further rise is when it goes and really enters and replicate. The next one, please. So I guess HIV does different things, like some other immunosuppression status that facilitates the key word in this field, persistence. Yes, some of the configurational changes of the proteins of TAP facilitate the entrance of HPV into the epithelia, but also the cellular immunosuppression at different levels facilitate the persistence of HPV that facilitates subsequent oncogenic changes that leads to dysplasia and anal cancer prevention. The next one. And on the topic of dysplasia and anal cancer prevention, this is a simple summary of what we see throughout time at the histological level. So you see, when the virus enters, it sort of produces some regular changes. When the persistence of the infection progresses, the epithelium gets wrapped, disorganized, very pyknotic, and until eventually develop anal cancer. 2 points to make. It's not a linear process. It doesn't go necessarily in a straight line from low grade to high grade and invasive cancer invariably. Point number one. And point number two, a common reason for the question is sometimes some of your patients or your report, you get the report to say in situ cancer, which is not invasive cancer. In situ cancer is simply a subjective definition of your pathology, is telling you that they are very concerned about the potential risk of developing invasive cancer. Simply is a patient with high-grade anal dysplasia. And there is no need for chemoradiation, surgery, or any other type of intervention. In situ cancer, it's not invasive cancer. It's high-grade A3 dysplasia. The next one, please. And to the point that to say that this is not really a very straightforward linear process, is because it's the same for the HPV infection. When somebody gets exposed to HPV and HPV starts to internalize and persist, throughout time, our body, when we are relatively immunocompetent, clears HPV quite efficiently. Yes, from all the HPV 16, 18, and 6, HPV 16 takes longer to clear, but we clear very efficiently most of the time. unless we have some immune risk factors that predispose to persistence. But as long as we clear, in a similar proportion, and these are studies done in relatively young MSMA between 18 to 13 years old, people get reinfected often all the time. And that modifies the complex equation of persistence, integration, regression. To the next slide, please. So the summary is that if you take into account all of these dynamics of the sequence of histological and natural history of progression, is as follows: that when an individual has an HCl, most people will stay within the stage of HCl. 30 to 50% could develop a spontaneous regression to lower grades, and a very, very small, tiny proportion will progress to invasive cancer. So eventually, some people will progress to invasive cancer. And here's the most important point. By providing antiretroviral therapy on the farthest to the left, I summarized the epidemiology status. Is a classical French studies already 10 years ago, and the epidemiology hasn't changed much. That despite antiretroviral therapy and boosting the immune status of our patients, the rates of anal cancer are not declining, which is sort of telling you early on our understanding of HPV, that once the HPV is established and persistent, even providing and reinstituting the immune system with antiretroviral therapy does little to the natural history of the disease. The next one, please. Something that we know is that a small proportion of patients who have cytology HCl, the immediate precursor of anal cancer, eventually will develop cancer. And the rate of progression is low, but consistent. All comers together, this number will modify, I'll show you in a second, is 2% of those individuals will develop anal cancer if we don't do anything within 5 years. And here's a conundrum, and here's a major dilemma. At the population public health level, you may think, well, maybe this is low. But at the individual level, there is no clinical biomarker, histopathological predictor that can tell you, you know what? I'm sure you have higher risk than the other ones to develop anal cancer. There are some elements that all clinicians try to follow, such as age, multiple lesions, etc., that give you the gestalt that this patient really is at highest risk and will not regress spontaneously. The location of the lesion, for example, lesions in the anal verge don't regress spontaneously as much as lesions in the internal scopocolumnar junction. But those are just individual observations. There is not really a good quantitative way to say, you know, you have HCl and your risk is higher than the other individual. And that's one of the major holes in the field. The next one, please. So why this is important? Because we need to understand that in general, I have shown you some evidence that it is the immune suppression, in this case, fostered by HPV, that facilitates the microenvironment for HPV persistence. And it is when HPV persists that leads to the anal HCl, which is a medial anal cancer precursor. But the progression to anal cancer is fairly dynamic and slow. But it's fair to say that despite antiretroviral immune reconstitution, the rates of anal cancer in patients with HIV have continued to increase invariably, and the same can be said for other population arrays such as solid organ transplantation. The next one. And then you can ask me, and this is a slide for you, Dr. Toperov, many of our patients in this question. So what is the role? I already was exposed. What is the role of HPV vaccine? I'm willing to pay out of pocket. I think I discussed with my surgeon after they did the procedure, and they tell me to talk to you so I can be vaccinated. I am 40 years old. I am 55. I'm okay. It's only $350, and it's quite safe. Please prescribe it. Don't you get these questions commonly all the time? And sometimes, with human compassion, project a lot of concern and anxiety in our brothers and sisters that unintendedly project the frustration to us. So I wanted to settle this issue with some data in a constructive manner. The next one, please. Undisputably, the HPV vaccine show in intention to treat analysis or per protocol analysis, which means when you vaccinate somebody who doesn't have any of the serotypes of the HPV vaccine, the protection is quite high, close to 80%. And when they have some, but not everyone, the protection is still some goes to 50%. So for primary prevention, for preventing warts or hematoplasia, is really quite strong and effective. The next one. The second point to make about the HPV vaccine is that looking at all the different studies, variations, permutations, and combinations of HPV vaccine, it's quite safe and effective, but it's also very efficacious in people with CD4 cell count less than 200, as long as they have controlled viral load. This is completely different, for example, when you think of hepatitis B vaccine, where the responses are imperfect and suboptimal to say the least, and are quite driven due to CD4 cell count, regardless whether HIV viral load is controlled. The nature of the vaccine works different in HPV. The next one. But to the point is, what about secondary prevention when someone is affected? And I think that's one of the most important studies, legacy of the ABRC. The ABRC participated in this ACTG 5298. It was conducted by Will Cornell, and Tim Wilkin was the principal investigator. Similar proportion of patients were enrolled to either receive placebo or the vaccine. Similar proportion of patients were distributed 1/3 white, African Americans, Hispanics. Most of them have suppressed viral loads. It was a very well done study. But here's the key of the matter. 1/3 of the patients at baseline enrollment already have histological and HPV HC lesions. Why did they include that arm? Because they wanted to make sure whether by doing the vaccine, in addition to the standards of care topical treatments that they can receive in their sites, that will change either the persistence of the proportion or the rates of anal HCl. And again, this was a randomized controlled clinical trial, not a retrospective or analysis where there are many anecdotes in the literature.
Did they know for those patients which strain of HPV they had?
They did. The next one, please. So you can look and dissect the data in different ways. But from the molecular point of view, persistent HPV, or even single detecting HPV at the last clinical visit, and persistent HPV was defined by having in 2 consecutive visits one of the HPV types that they were not present in enrollment. There was no difference. And here's the more disappointing finding. When somebody with histological HCl, the hazard ratio, it was 1. No benefit or whatsoever, unfortunately. And also the data shows you that, unfortunately, when somebody has NLHCl and being exposed, there is really little to no benefit actually for secondary prevention, and goes along with the fact that how the vaccine works. For altering persistent HPV, you really need to have some sort of other immune approaches that changes that perspective, and there are some coming in the foreseeable horizon as a potential randomized clinical trial. The next one, please. But I don't want you to really get disappointed or pessimistic. Let's keep on an eye bit. And there is some important modeling coming, and this study is very optimistic, showing you that when you actually start modeling the rates of anal cancer in the general population between before and after 2008, when you start vaccinating for HPV, you see how the rates of anal cancer start to decrease, particularly in the younger population, on those who were vaccinated, which is consistent about how important it is for primary prevention, but not so much for secondary prevention. So the next one, the message to you all is vaccinate your family members, your brother, your sister, your children, your patients, everybody who can benefit and is on an age appropriate of HPV prevention. Indisputable, the guidelines for HPV are, we don't see much pediatrics. Some of our colleagues do at the Wayne Clinic when they are before their sexual initiation life. That's really the ideal time. Yes, people with 526, they catch up. We still have provided the vaccine, although in patients with HIV, the rates are much lower. This is a study, a national study where we participated when we enrolled patients between 18 to 24 years old, and 1/3 of them already had anal HCl when they were HIV positive. So it's telling you why it's less effective. What are the official recommendations according to the DHS HIV guidelines? between 27 for 40 years old is really not recommended. Not much beneficial for the patient or for the public health. There are very individual circumstances that may benefit from a shared decision-making approach when you feel that the patient really has no exposure or whatsoever and might be or minimal exposure to say in terms of intimate exposures and will benefit. But it's not, it's actually contraindicated. Yes, Jill,
Contraindicated,
it's not recommended.
not recommended. What if, I'm just trying, because I feel like this is something that may happen when, patients come to us later in those ages. Would a strategy of doing an anal pap smear, and if there were no cells, then that would be a perfect reason to give them HPV vaccine?
Well, it's one of the potential, so if you don't anal pap and they have no atypicals and you don't
Yeah.
HPV DNA and it's negative, well, then you engage in a shared decision making. That's one of the things, that's one of the ways how I do it. Not
Yeah.
perfect, but that's how it works. You can argue that there is potential benefit. For example, I have a female patient who crossed the border 20 years ago, got infected with HIV, well, et cetera, minimal exposure, et cetera. She's 35. I do exactly what you said. Then I think she will benefit from the vaccine.
About like increased risk with more strains being acquired, is there thought that protect them strains that you haven't contracted might be used?
So for that, you go to the intention to treat analysis. So the per protocol analysis of all these clinical trials give you the level of protection for the strains that the vaccine covers. The intention to treat analysis actually plummets the rate of protection. I cannot tell you for sure that it will be a theoretical, but I think without a doubt, most people have been exposed to the most common HPV. Yes, Laura,
Was the ACTG study done with the quadrivalent or the non-covalent
with the
vaccine?
quadrivalent vaccine.
Maybe we don't know with the
We don't
non-covalent.
know that for sure.
Yeah, okay.
Next one. So far, based on the evidence, we know that the HPV vaccine is quite effective for primary prevention. Not useful based on data for secondary prevention once you have already established disease. But on the positive bit, there is important ecological data of the effect of HPV vaccine on renal cancer incidence amongst who have been vaccinated at a relatively early age, as you will predict. The next one, please. However, I want to make the point that we have still quite significant number of people, close to 500,000 at risk of renal cancer in our country. I'll talk about it. Let's go. The next one, please. So let's center in the most important treatment of renal cancer. The next one, because for decades we were discussing, well, shall we screen, shall we treat? And this is what we do, right? If you find a patient, like in the left-hand side, you have like a set of white, like a high-grade, like looking lesion, you ablate either with hypercarrier or with recoagulation, you destroy the lesion, and you try to prevent in that way that the disease progresses. So we've been doing this routinely for 20 years at the World Clinic. So the next one, it was controversial for a long period of time until the Anchor study came. I show you that there was a relatively risk reduction of 50% of progressing to renal cancer on those individuals who were treated rather than those who were simply monitored. There are caveats and small details that are being sorted out with the Anchor study. You could argue that the 0.2 difference of the incidence of renal cancer at the population level, it was little, but when you see the life expectancy of the patients that they are living for a long time, that could potentially be quite beneficial. But having said that, the next one, the most important point is that besides the postoperatory discomfort, there are important pluses to this intervention. Number one is an outpatient operatory intervention. The patient can, inside, continue with his her normal life. Number two, yes, there is some minor discomfort, as you will expect from a surgical intervention, but nothing like 15 years ago when you go to surgery, where you are unable to drive for 1 month, when you need to sit in a special, Donna-like cushion, nothing like that. And in general, the rates of adverse side effects and poor tolerance were infrequent in the Anchor study and similar to the clinical experience. The next one, please. So the next one. The real question is, if we now have quite important evidence we have discussed so far of the burden of the renal cancer, how much is affecting public health. If we really now have a little bit of better understanding what works and what doesn't, and there are many holes that needs to be addressed, and we have a proof of concept of treatment matters in a positive way, why we are not really doing more renal cancer screening? What is holding us back? And this is sort of a conceptual framework that is in my mind. It's not definite, I'm sure there are many other factors, but it's not just one thing. It's a myriad of factors. From the patient perspective, let me remind you that those issues discussing anal symptoms, it's associated to different stigma misperceptions. Also, lack of awareness, HPV literacy. The fact that, they don't trust enough their providers. From the provider perspective, that we have some implicit bias, and we sometimes feel you are at highest risk than the patient that I saw earlier, and I may not be so assertive in the way how I screen you. Perhaps the way how you communicate or how communicate with my patients, I'm not able really to get to the message in a really very effective manner, and the ability to build trust. So those factors influence, but there are also important health system barriers. The most important one is that we work in a very paternalistic approach where we treat guidelines like mandates. But guidelines are expert recommendations that needs to be tweaked based on clinical judgment. They are not mandates. The lawyers look all the time for the legal arguments, but clinically speaking, they sort of guide you to have a conversation with your patient, and they have not been harmonized. Very variable over the last 15 years. That's one. Number two, there are very few centers and high resolution certified available providers. We hope to change that, and I will expand more on this concept. And importantly, there are constraints with time, chaperone, policies, misperceptions, legal risks for which, sometimes providers don't feel compelled to engage, and all of these things are real. So multiple layers of factors that really we need to concurrently address with compassion, with sympathy, and importantly, assertively, so we can make a difference and break those barriers. The next one, I have some thoughts on this. So, but the real question is, well, yes, we need to scale up screening, and how do we screen, and what are we doing nowadays? I'm not going to speak about theory. We have the problem now, and we want to overcome the problems with tools that we have. And I'm focusing the talk in those tools. The next one. And so far, what we have are only two things: our fingers and a swab. But let me be clear on the sequence of the order. Our fingers and a swab. Everything starts with the digital rectal exam. And a swab, in most of the cases, is anal cytology. And although not FDA approved, many centers use HPV high-risk DNA in different fashion and forms, and I will expand on this. But those are, in reality, the only two available options for renal cancer, plus symptoms and other potential alternatives. But those are the current standard of care. The next one, if you were to have any abnormality, you find a lump, you find something indurated, something that doesn't feel right on your digital rectal exam, or you have any abnormality in your renal sap, atypical cells of unknown significance, low grade, of course, high grade, etc., then you refer the patient to a high resolution endoscopy. Because now, since you are collecting this sample blindly, you are not seeing. The idea is that you convert this virtual into a real space. You look with a microscope through a high resolution endoscopy, and you try to find the lesion they've sealed or lesions that will explain and hopefully subject to ablation and destruction, like the anchor study. The next one. And here's the point where you would say, well, what about HPV DNA? How are we treating it? How are we using it? Why are not we really using it on everybody and only in some patients? The next one. The summary could be shaped in different forms. I haven't included methylation analysis and other research biomarkers, but HPV DNA, microRNA 6/7, like in cervical dysplasia, P16, K160C immune stains, and all of those markers, particularly HPV DNA, when you add to anal cytology, number one, it doesn't increase the sensitivity. And number two, In every single study, regardless of the shape, form of the site design, the specificity goes down. So if it doesn't increase your sensitivity and your specificity is going to be lower and you're going to increase the cost, really, it's not going to be useful. Why are we including in some expert guidelines, in some of the new guidelines coming? I think it's a matter of controversy, but I think it's just to use it in another different strategic manner. It's the next one. However, I don't want you to get the feeling that HPV-DNA is not useful. It's just we need to know how to use it. The real question is why it's not useful? Why it's different in persons living with HIV? There are a couple of things that are different in persons with immunosuppression, especially those with HIV, and those with anal dysplasia. Number one is that if you were to do an HPV-DNA anal swab in the anal canal, at any given time point, you will find not one but multiple types of HPV. Specifically, at least 1 million of 3 different types of HPV DNAs. High risk, all of them. Concept number one. Concept number two, unlike cervical dysplasia, where you have this concept, one virus, one lesion, you do the HPV DNA swab, you find HPV-16, you do the cervical biopsy, HPV-16 in the tissue, no questions asked, treatment removal, the next one. In the anal canal, it's quite interesting. There is so-called immune compartmentalization effect, where up to 50% of patients, the lesions that you actually found on the biopsy are not picked up by the HPV DNA swab. And I think those are holes that we are still trying to understand. But is HPV DNA not useful? No, that's not the message. The next one. Because in the reality, what we have right now is a huge need. We really are trying to have a conversation today how we can improve better this public health crisis of anal cancer screening. And our major limiting factor is access to high-resolution endoscopies. There's a very interesting mathematical model just published recently that you say that if you do an anal cytology in every highest risk individual in the United States, mainly MSMA with HIV, approximately 420,000 patients will require a high-resolution endoscopy. And based on the current status of access to care, almost 1/3 of them will never have a high-resolution endoscopy. An important proportion of them will provide cancer. So, how can we do better with the current results, tools that we have? The next one. So I think it's combination of strategies to try to prioritize how we can strategically access services for high resolution endoscopy until we have better strategies to scale the task force. And I want you to, this slide that I changed throughout time summarizes the concepts of our strategy. Number one, whoever chooses a strategy needs to maximize the number of procedures that you're going to do that efficiently pick up one patient with anal HCl. Number one. But as importantly as maximizing the rate of specificity of when you do a high resolution endoscopy, that you don't need too many to pick up a patient with HCl, is the other part of the equation. That you don't miss too many who already have HCl. And working in a non-universal healthcare system where costs are an important part of the equation, that the strategy that you pick up is somewhat cost-effective. With that strategy in mind, you will see that if you were to do high cytology and HPV DNA on everybody, you will have a surge of patients in need of high resolution endoscopy and a surge of unnecessary procedures, only few with NLC, and a huge amount of increased cost on your health system. But if you, on the other hand, do cytology, and in those who have ASCOs, you automatically do a higher reflex for HPV DNA, and you only do HRA on those who have ASCOs and also high-risk HPV DNA, then you maximize the efficiency of your HRA, you minimize the numbers of false negative studies, and your cost is intermediately decent. The next one. And I think this is important because in most of the population cohort analysis, like the one clinic, There are studies that are done with convenient samples of high-risk populations, but in most clinics, the distribution of anal cytologies is like this. Close to 2/3 or 50% of the anal cytologies are ASCOs. And according to current screening, they need a high resolution endoscopy. You see the amount of pressure that they impose in access to care. So if you try to create a strategy for screening that facilitates efficiently who needs an immediate high resolution endoscopy, such as risk of HPV-DNA, then at that particular moment, HPV-DNA could become a very useful tool. And this is how we do things at UCSD in general. The next one, please. So key points to remember about anal cancer screening. Of course, everything depends on the digital rectal exam, which, by the way, is hugely underutilized. Because think about this, many of you who work in clinic like me and primary providers, we really focus on introducing the swab and taking a correct sample. But I can assure you that in most of the circumstances, we tend not to complete a digital rectal exam, meaning a full examination of the anal canal. But that's important. And the HPV DNA facilitates strategies how we can efficiently facilitate the screening when high resolution endoscopy task for access seems to be limited at present time. The next one, please. And the most important topic with all of this evidence, where are we, who we need to screen? The next one. There are expert guidance, and everything right now comes into expert guidance, and the first official guidelines came from February of this year in 2024 by the International Anal Society Neoplasia. There are no yet updated DHS HIV guidelines and any other national guidelines, but this international group of colleagues is telling us the following, that we need to screen everybody who have a rate of more than 70 per 100,000 of rates of incidence of cancer. And it's pretty much every patient living with HIV, every woman with vulvar cancer, whether they have HIV or not, MSMN without HIV, transgender women without HIV, and of course, patients with immunosuppression, with solid organ transplantation with more than 10 years of history of immunosuppression. Those are the official recommendations from this expert society. And the next one, but they added an important tweak that has created some conversations. They try to create ages for which we and when we need to screen and start screening. And one of the most important ones that has sparked some conversation is the age when we need to start screening. And they recommended to start screening in patients with HIV, MSMA when they are 35 years or older. And similarly for trans women, I just want to say that simply for trans women, there is no data whatsoever, transgender women, and many of the populations that they are including in the table, simply there is limited data. Everything comes with a meta-analysis from Clifford et al. And the basis are when they start enrolling patients in the Anchor study. But the Anchor study, it was a very important, unbelievable proof of concept, but really didn't tell you when to start screening. The next one. So the real question for you is, so why? Is because anal cancer doesn't really happen in people younger than 35 years old? What are the data shows? So here's, I have a flavor for you. Very interesting findings, and all of them, except one study, all of them are relatively recently new studies. The next one, please, Will. We have 3 large studies, 2 in the United States, 1 in Spain. The first study, it was done among younger people in the US military in the early 1980s and 1990s across 7 clinics in the United States. She interestingly found that 16% of patients diagnosed with anal cancer, 16% were under 30 years old, all of them with HIV. In our experience, 1 patient was diagnosed at age 21, a transgender patient, and 1 patient at age 35, but start having symptoms at age 33. If we have not started screening earlier, we could miss important patients like this. But a national study, the Coris group from Spain, where they have a very interesting population distribution, show that close to 20% of their patients are diagnosed before age 35. And importantly, it's the only study that provides an epidemiological description of the rates. And the rates are 19 per 100,000 years of follow-up, which is much higher than the 17 threshold and the International Renal Society neoplasia. So all of this to say that, the next one, please. At the Owen Clinic, we start screening at age 25. Now, one of the comments that you will see often in guidelines is the one that I'm showing you, that if there is really no high resolution endoscopy, please don't do any anal cytology. Focus on your digital rectal exam. That's what most experts favor in the guidelines. Where is this data coming from? And do you really, and do we really abide to digital rectal exams in the clinical context? There is no data, but I suspect that the adherence to those recommendations are extremely low. But there is an important piece of additional information that is coming. And the next one, please. And I think this data coming from the Owen Clinic, where unlike convenience sample cohorts, you have a population that has been followed for close to 20 years, in whom, as part of an insertion cohort, you do and offer anal cancer screening to everybody with variable uptakes, because the screenings and the recommendations and the guidelines have been variable. The patient might decline, the provider might feel that it's not indicated, but it's a universal recommendation for the last 20 years. And the data shows you that from more than 8,000 patients, approximately almost 1 in 2 have been screened throughout the history of our clinic. At baseline, 12% have HCL cytology, and in subsequent anal cytologies, 10% also have, for a total of 22% of people throughout time that they have HCL cytology. Eventually, 33 of these patients develop invasive anal cancer, and regretfully, 7 of them died due to cancer progression. Now, different complex statistical analysis adjusting for the population at risk, the rate of screening, etc. Look at the most important. Can we look at predictors using data in the electronic medical records available to the clinicians when you are caring for the patients, and say who really is a higher risk of anal cancer based on this information? Well, and the short answer is that we observe that most patients who develop anal cancer, they have refused to have a high resolution endoscopy. All of them who die, they actually die because they were diagnosed with relatively advanced stages, clinical stages 3A or more, which means two things. Either you have a tumor of at least 5 centimeters or more, like a little lemon, or if it's smaller, you already have peri-local lymph node involvement. So we miss opportunities to screen them earlier, or often they refuse. In fact, all of the patients who die, they have opted out recommended infrared therapies. The next one, please. But here's the most important factor. When you look at those predictors, okay, I'm with my patient. How can I tell them whether they are an increased risk of anal cancer? I don't have high resolution endoscopy available next to me. Well, the data is telling you that only having a time-updated HCL or having a low CD4 cell count less than 200 are independent predictors of who will develop ultimately anal cancer. But more importantly, look at the lower table, and I think this is the most important finding of this Owen Clinic contribution, that the presence of CD4 cell count, how immune suppressed was individual, really affects significantly the effect of having HCL. Whereby those who actually have anal HCL time updated or an CD4 count less than 200 have a painful higher risk than individuals without those characteristics. Next one. If you are somebody like me who say, well, those are statistics, hazard ratios, what does it mean at the population level or individual level? That sounds very interesting, but maybe the effect is not as prominent. At the individual level, tell me, what's my risk if I have those characteristics? Well, to put things into perspective, if you look at the risk in our entire cohort of more than 4,000 individuals, the 5-year risk is 0.63%, and the 10-year risk is 0.80%, less than 1%. Okay, that's little. But, however, if you look at the Kaplan-Meier in the left-hand side, if you have a patient who have an ideal CD4 cell count less than 200, and a time ever updated presence of NLH-seal, the risk of an individual goes from 3.4% at 5 years to 4.27% at 10 years. And this is not mathematical modeling, this is real data. How many patients we have that they have AIDS and been diagnosed in the 1980s, early 1990s, and they are living normal, well-controlled life? Wouldn't really a patient like to know this information? So the next one, please. And so and I think this is a practical example of a patient who really in the era of non-harmonized era have NLH-seal. We recommended a high resolution anoscopy. The patient politely opted out, and 5 years later came with a very invasive renal cancer, the one that you see, unfortunately. Luckily, it was a stage 2B, and the patient went through a complex process but survived. The next one. A lot of complications in the therapy. So what are the key points with this additional piece of information that fairly wasn't available by the time when the INA's guidelines were being redacted, because this data was just presented at CROI in Denver, is now available online. I think expert guidelines really not necessarily are personal opinions from many experts, but they don't align necessarily with the values, preference, or risk ascertainment of our patients, who they would like to know this data and seek more assertive strategies to access other type of interventions and screening, or perhaps increase the uptake of more frequent digital rectal exams in patients that will not prevent cancer, that will capture a relatively early stage. Certainly, many patients would like to know this. The next one, please. Now, there is a common question that happens is, at what age do I stop screening? Is there such an age? Is there such a recommendation? The short answer is no. Next one. And just as a context, a question for Dr. Wilcott. As you know, cervical cancer screening stopped around age 65 in women in the general population, when there are no risk factors and you have performed negative screens, etc. There is no recommendations in people living with HIV. And I wouldn't say that intimacy stopped at age 70. That would be a myth or a misinformation. But I would say that we are trying to incorporate common sense algorithms that try to provide with data an efficient way, because it's like a chronic trail of constant screening that induce patient fatigue as well. And you want to use human compassion and common sense in your approach. And the idea that we are trying to say is that if a patient is 70, has the patient ever had an NLH-seal based on the data that I show you? And the short answer is not. Do you have a recent NL cytology in the last year and or biopsies with an HRA? And in our institution, we have a high-risk HPV DNA. If all of those are negative, then we stop screening. They continue their care with the primary care providers, and the primary care providers follow them periodically and can ascertain in the individual conversations if life circumstances changes, and they may resume anal pap and other type of screening. And that's sort of an approach that we are trying to implement in our clinic. The next one, please. What are the key points of this popurrí of screening that we are trying to discuss with these changes in variable guidelines? Undisputable that all patients will benefit from anal cancer screening, all of them. And the UCSD screening, our protocol screening starts at age 25 based on our data. We don't like our brothers and sisters to have anal cancer of any kind if we can prevent it. At age 70, we can reassess the needs of ongoing screening based on patient risk and information. This is not a national guideline. It's really an approach that we are trying to take at our clinic. The next one, please. And let me finish with very important. How can we overcome the stigma of misinformation? And you often will say and find this question with your patients in clinic. Doctor, I'm never engaging in anal sex. Why do you want to insert this anal swab on me? And some people get a little bit offended. And we just have discussed that it's not about anal sex, it's about immunosuppression and persistence. In fact, the recent data of the nadir CD4 cell count as an important modifier tells you that if the patient develops important immune suppression, most likely they already have incorporated oncogenic HPV, and that would not change the die, despite antiretroviral therapy. That's what the data is showing you. So the next one, so why this is important to speak about stigma, so we can really be inclusive, compassionate, humankind, and understanding. We have these conversations because really many people feel reluctant and to openly discuss the symptoms, and they postpone it. And this is a patient who had these symptoms for almost 2 years and really didn't want to address it openly with the provider, and with Ken already have this obvious lesion with the outside that it was actually an anal precancer lesion. The next one, please. So what are the approaches? And I want to give you some general thoughts, food for the thoughts here. There are many approaches, but clearly we need to create awareness, and educations and campaigns. And I think in addition to HPV vaccination, we really need to create awareness in people about the potential symptoms and the importance of screening. I think it would be important to quantify the risk. So we don't engage in subjective perceptions of who we think is the risk and who is not. If you have a mathematical number that helps you to drive the conversation, it will be more objective. And I think it's important to discuss anal self-examination or examination in the presence of the partner, because no matter what you do, many patients will simply get reluctant to have an anal exam. So the next one, and to finalize, we are doing at the own clinic, if you do different patient characteristics, CD4 cell count, race ethnicity, nadir CD4 cell count, etc., you can calculate a risk, and you can predict what is the individual probability, whether the patient, like if you were to engage in doing an anal swab, this patient, the chances of having an anal HCl, that subsequently will trigger additional screening. So you want that type of information before you engage in the conversation. This is validated according to the one's clinic, and with population health, we are hoping to implement this within the next 3 weeks. The idea is to have a calculator when you are in your clinic with your patients, having a conversation with them, you know, by the way, based on your individual characteristics, your risk of having a potential anal HCl, if I were to do this anal pap, is 7%. What does this number means? That next one, you can engage in a shared decision-making conversation. You know, for every 25 patients with a probability of 6% or more, you will be missing at least 4 patients with anal HCl if they refuse or opt out. But at least you have a number to discuss, and really, rather than focus on stigmatizing or sometimes, you know, perceived as offensive questioning about individual sexual practices to the patients that many don't welcome. I could understand why, but I think you can focus about the individual risk based on a model that really can guide the conversation. But then the final slide that I want to show you is this one. There is very important data, a study done in the East Coast that shows, hey, there are many patients who don't want to have really anal pap. They don't want to be examined by their providers. There is some data about HPV DNA that people can do cell swab. What I already showed you, that if you start doing cell swab on everybody, you will have a huge number of patients with HRA. We also know with our own data that those who die with renal cancer is because they have large tumors and advanced disease. If you cannot really prevent from having cancer, can you prevent them from dying of the condition? And for that, I think it's very important to teach patients how to do self-examinations. And they did this study with patients in 5 minutes, showing them in a manikin what they need to feel in the anal canal, and then letting them do self-exams, and they correlated the findings. And as you can see, the patients or their companions were very good in identifying lesions, depending on the size, and all of them were actually less than 5 centimeters, which means that the higher the lesion, the easier for the patients to detect, but they need to feel something that is only 1 centimeter to be meaningful detected by the patient. And they say, hey, I feel something. And at that moment, they may be more open to have a conversation with their providers. And I think it's something that we are not exploiting meaningfully to try to address perceptions, concerns, and reluctance of the patient. The next one, all to say that anal health issues are surrounded by stigma. And we really need to understand that delays sometimes in some of our patients' access to medical care. Quantification of risk might help some, not everybody engage in screening in a very unbiased manner. I think an underutilized resource in general is special self-education about doing anal self-exams. The next one,
Lalo, it's 8:56.
I have a drink and I finish this.
So sorry.
And I finish with my dream slide.
Really
My
messed
dream
that up.
slide, something that I will see probably in my lifetime. We are talking now with the World Health Organization about cervical cancer elimination. And these are really our parameters: vaccinate, screen, treat, and prevent. I think in the last 25 years, thanks to the work of multiple people, important concepts has been accomplished. Now we understand the importance of screening and treatment. We have still some minor issues to sort that out for access. And my hope is that someday, when we have more defined access to care, strategies for screening and prevention, we can be discussing in the foreseeable future, also, can we now eliminate anal cancer from the picture? With that, I will take next one, please. I will skip the next one. I would like to, it's a really a work for multiple people in the clinic for the years, people who have contributed to the high resolution endoscopy clinic at different levels. And I wanna thank foremost our patients. Their resilience, their commitment to their care is an inspiration to us and the reason why we keep going. I'm happy to take any questions and whatever is in the chat here.
Um. Someone has a question about patients self-collecting anal pap. It was sort of a, what did you say about it? I don't know if you have sort of final thoughts about whether you think that's a feasible strategy. And maybe, here in our clinic or in San Diego in general.
I think it's a very good thought. There are challenges with anal cytology, and all of you know. And one of the challenges is that it's relatively, compared to the cervical, it's hypocellular, meaning that often you have less than 5,000 cells per ml of self-collecting cells. The reason why we try to teach our medical providers to collect it in a way that is meaningful. It's something meaningful to explore. I think it's better than nothing. But I think I am concerned that if you don't do it well, you can provide self-reassurance to a patient that is not collecting the sample properly. I think it's worth
Yeah, I
exploring.
was gonna say, is it better than nothing? And someone is like, there's no way I'll do it.
I have a quick question. In the beginning, you were talking about HPV persistence and cancer progression in relation to immune suppression. I'm thinking about KS and Dr. Reed always saying no steroids, even topical, no topical steroids. Is there any concern about treatment for hemorrhoids with hydrocortisone cream or something like that in relation to HSIL risk for progression in regards to what it's doing to the tissue in the anus?
The short answer is I don't know, Aaron. But I suspect that because the treatment courses are relatively for a short limited period of time, and this is long-standing progression of disease, you may have little impact. Because when you use aerosol for a hemorrhoid flare, you probably use for 7 days. And remember, this disease progresses in 5 to 10 years.
It's 9. I want to be careful, but maybe we can end it. There was, Nettie had a really nice comment for you. Thank you for your excellent talk on a hot topic, highly relevant to providers and patients. Still very much an evolution. You hit all the important questions we face in the clinic, and she can't wait to see the risk calculator in the App Store. I think this is a great question to leave us on, though, from Sarah Rojas. Hi, Sarah. How do you think we can best increase access to HRA? I know that's a big question.
So with that mathematical model, based on the current existing task force, it means that if we were to duplicate the number of available providers in the United States, all of them will need to work at maximal capacity, seeing approximately 30 patients per week to try to accommodate needs, which is not feasible. So I think we need to facilitate strategies while we sort that out a biomarker, such as not only creating reflex HPV DNA, access to really those who are at the highest risk. I just showed you data that not everybody with HCL is the same risk. I will prioritize those who have HCL, and I can argue history of Nadir C for Cercables 200. There are criteria right now that are evolving for what it means to have access to high resolution anoscopy. And I think the acceptable rate is no more than 6 months. When you are more than 6 months, that means that there is something urgent needs to be done. We are sort of touching that level at our clinic. It's like 5 months, right, I think. So, yeah, I don't have any magic solution. There was a very interesting conversation in May 15 at the state in Sacramento with the California Public Department of Health, where the CDPHC is trying to create a task force to try to create access in county clinics and STD clinics and training for everybody. The challenges for training for everybody is that this is not a specialty dependent, not a degree dependent. It's not just for physicians. Any APP could do it. It's also not exclusively for infectious disease, oncologists, GI doctors, or surgeons. And how to go about the regulatory framework, how to train these individuals. I think the state is being involved and more to come in the next 6 to 9 months.
Thank you.